I've been strictly instructed to give a very high-level talk here, and the cancer immunotherapy world over the past, really the past 3-4 years has been the hottest area of drug development in oncology. And even in terms of cancer immunotherapy, there are several classes of these agents that are really hard to summarize in 20 minutes. And that's a good problem to have. We have a lot of new promising agents, a lot of new promising activity across various solid tumor types. So, however, today I'm going to mainly focus on immune checkpoint inhibitors. And immune checkpoint inhibitors have been shown to be effective lately in several solid tumors which are otherwise hard to treat. And I will try to summarize why immunotherapy should work in cancer, and I will try to summarize immune checkpoints. I'll try to just give you a brief overview and give you a flavor of some of the immune checkpoint inhibitors currently under development. And if time permits, we will try to talk about immune-related adverse events. So over the past several decades, we have made some advances in management of cancer, and from being able to treat cancer as a cancer arising from breast, lung, we have become more selective in our approach. We have been trying to direct treatments based on histologic classifications over the past couple of decades. And more recently, in the last decade, we have had tremendous advances in our understanding of cancer genetics, cancer biology, and that really made a huge impact in terms of how we are managing and how we are diagnosing cancer and our approaches. But however, over the past several decades, we have been mainly focused on combining various cytotoxic chemotherapies and trying to add drug A plus B plus C, and we haven't really made a significant impact in our outcomes with advanced solid tumors. And however, with targeted therapies, we do see improvement in survival across diseases based on the target, and however, we don't see long-term survivors. And what we really need in oncology is being able to move the curves, survival curves up, and that is where cancer immunotherapy comes in. And the main limitations with targeted therapy is most solid tumors that are really hard to treat and really challenging as an oncologist to be able to treat these patients and see no response. The reason is they're highly genomically complex. And the complexity ranges from inter-tumor heterogeneity to intra-tumor heterogeneity, and also evolution of the heterogeneity in cancer genomics with treatment stress and Darwinian selection of the clones. And essentially, despite of all our efforts, we really have a tough time making a huge impact in patients, in most patients with solid tumors with cancer treatments. So we need a paradigm shift in thinking about our strategies to treat cancer, and cancer immunotherapy is very attractive for the reason that we have been trying this for a long time, but with immunotherapy, you activate the immune responses and have relatively non-specific targeted approach because your immune system can be trained and be used to target several neoantigens which are cancer-specific. At the same time, it allows for that to adapt with the treatment changes in the tumor microenvironment. The advantage with using anti-tumor immune responses is that you have a very high degree of specificity to the tumor-related antigens, and also there's an incredible diversity of these T cells to various tumor-related neoantigens, and there is memory. And in short, if you use cancer immunotherapy, we expect patients who respond to have a longer duration of response than targeted therapies or any cytotoxic therapy. And we do see this in a lot of our human experiments with immunotherapies. This is a common theme across various immunotherapies. Most patients who respond have a long duration of response. Just to illustrate, this is my patient that we treated in 2010. She had metastatic non-small cell lung cancer, and she has KRAS mutant adenocarcinoma, very hard to treat subtype of cancers. And she had 3 prior lines of chemotherapy, and she essentially had no significant response, and she presented with extensive bulky disease in the liver and excruciating pain, requiring several breakthrough medications, and has like several visceral mets. And we treated her with this drug, MDX1106, which is now nivolumab, which is a PD-1 inhibitor. And within 2 cycles, you see the scans here, she had like a near complete response in the liver, and a very remarkable improvement in her pain, and overall clinically she had a remarkable improvement. And what's most exciting is she continues to have this great response, and she has a near complete response at nearly 5 years. And what's even more exciting is she was on CNN talking about cancer immunotherapy in August after the ASCO meeting. So that is I think, the most fabulous thing ever. So this goes to tell you, there's really a subset of patients. I mean, unfortunately, not everyone responds to these drugs. We'll talk about that in a second. But for the ones who respond, the response is quite meaningful. And just to introduce the concept of immune checkpoints here, I know it's a complicated illustration here, but I just want you to focus on the 2 different types of immune checkpoints here. For T cell to get activated, as all of you know, you need the initial signal with the T cell receptor and the antigen and the MSC presentation. But however, you also need the second stimulus, and that is contextual. It depends on where the T cell is and the microenvironment and the context of activation. So you have a whole slew of co-inhibitory and co-stimulatory receptors on the T cells, and the co-inhibitory receptors, you have a lot of ligands, mainly the B7 family ligands, which are expressed on in the antigen-presenting cells or in the tumor cells, and the activating ligands, the TNF family ligands, which are either on the tumor microenvironment or in the antigen-presenting cells. So PD-1 and CTLA4, which are the 2 pathways that I'm going to really focus on today, are co-inhibitory pathways, and essentially they mediate tolerance, and tumors use these pathways to actually shut off the anti-tumor immune response at the level of the tumor or at the level of the antigen presentation. So there are obviously several drugs being developed against these immune checkpoint inhibitors. And there are inhibitory receptors, and like I just said, CTLA4, PD-1 are inhibitory receptors on T cells, and there are several drugs under development, and so are LAGE3 and Vistar and TIM3. These are also active targets for drug development. We won't go into those today. But CTLA4 and PD-1 are the targets that have drugs that are currently FDA approved for use in various solid tumors. And there's a key distinction between the CTLA4 and the PD-1 pathway. CTLA4 is mostly in the immune activation phase. It is slightly non-selective in terms of activation of the lymphocytes, and however, PD-1 is a pathway that's important in the tumor microenvironment, and tumors express the ligand for PD-L1, and this is more in the effector phase of the immune response. So as you could imagine, CTLA4 is early activation, and so it actually causes a more robust immune proliferation and activation of T cells. However, it's less specific, but the PD-1 inhibitors actually, PD-L1, PD-1 pathway is more important in the tumor microenvironment, so it is actually in the effector phase of tumor immune response. So it is, we see less of autoimmune toxicities with the PD-1 inhibitors compared to CTLA4. So, however, that said, there were like several CTLA4 drugs which are currently in development. However, ipilimumab is the only drug that is FDA approved for use in melanoma. And that's based on this clinical trial, which showed significant improvement in overall survival and also long-term survivors with ipilimumab-treated patients. This led to FDA approval in previously treated and untreated patients with advanced metastatic melanoma. And in terms of the development in in non-small cell lung cancer, ipilimumab was studied, however, was studied in combination with chemotherapy, and it was given in concurrent to standard treatment with carbotaxol, and the other arm had chemotherapy followed by ipilimumab. And this trial was a negative trial. However, patients who received chemotherapy and had ipilimumab after that had a slight progression-free survival. And the general perception in the community is that the steroids that we use for patients with getting chemotherapy may dampen the immune response, and because of the lymphopenia that ensues with high dose of steroids during chemotherapy. And most of these patients are cytopenic during chemotherapy, so that is probably the reason why we didn't see enough efficacy in non-small cell lung cancer. However, ipilimumab is no longer being developed as a single agent in lung cancer. However, it's been developed in combination with PD-1 inhibitors. So PD-1 and PD-L1 inhibitors, there are a lot of drugs currently under development, but today we will mainly focus on nivolumab and pembrolizumab, which are the FDA-approved drugs. And there are potential differences between PD-1 and PD-L1 inhibitors. I would not want to go into that at this point. If somebody's interested, we can talk about it in the session. So nivolumab is a PD-1 inhibitor that is currently FDA approved for use in lung cancer. And this is the early phase clinical trial in which my patient that I had just shown you was on. And they saw activity across various tumor types, and they had expansion cohorts and follow-up studies in those tumor subtypes. And what's most interesting is that in patients who were on the early phase clinical trials, we were seeing durable responses, unlike any other treatment or any other cytotoxic chemotherapy in the past, or even, for that matter, even targeted therapies. This was a phase 1 trial, and all the patients on this trial were heavily pre-treated patients, like my patient who had 3 prior lines of treatment and have extensive disease burden. And in this population, they were seeing a 1-year survival of 42%, which is quite remarkable. So this led to several subsequent trials, and this is a trial that closed to accrual, and this is in previously treated patients, and this is a phase 2 trial with nivolumab single agent given every 2 weeks, 3 milligrams per kilogram. And here I just want to highlight one fact, though, the overall response rate, it's only 15% of the patients who had a tumor response on scans based on RECIST criterion. However, what's most exciting is the duration of these responses. And again, in this subsequent trial, the 1-year survival in this heavily pretreated population was 41%. So that is pretty darn impressive. And also the side effects or the immune-related adverse effects with nivolumab were very minimal at best compared to what we are used to seeing with cytotoxic chemotherapy. And in fact, these are a very well tolerated group of drugs, and we'll talk about the immune-related adverse effects after a few slides. So. And there was another trial which is actually a randomized trial comparing standard cytotoxic chemotherapy to nivolumab. And in this trial, we saw significant overall survival benefit. And this was a trial that led to the FDA approval of nivolumab for use in squamous cell lung cancer. This was a trial that was done in squamous cell lung cancer, and there was overall survival benefit with nivolumab compared to docetaxel. And this study hasn't been published yet, but we will be hearing some updates at ASCO in June. And similar to the other trial design, there's also a trial currently ongoing in non-squamous non-small cell lung cancer. And even this trial, as of last 2 weeks ago, this trial was closed early due to efficacy, and they had a first interim analysis and they had to stop the trial, and the data is being reviewed by FDA right now, and I'm almost certain that this is going to be approved for use in non-squamous as well. And it's a similar story with pembrolizumab. So there's another drug. It is also a PD-1 inhibitor. I won't bore you with all the details, but essentially it follows the same track. The phase 1 trial looks really promising in various subgroups, and they see efficacy across various types of cancers, including lung cancer, highly refractory lung cancers. We're seeing like tremendous response rates, and MPDL3280 is a anti-PD-L1, and this is not FDA approved yet for any disease, but however, this looks promising as well. And even with this drug, we are seeing efficacy across various solid tumors, and we do see some differences in toxicity with PD-L1 inhibitors. So unlike PD-1 inhibitors, PD-L1 inhibitors don't have pneumonitis due to certain differences in immune checkpoint activation in the lung that can mediate pneumonitis. And we think the PD-L2, PD-1 interaction actually what mediates pneumonitis in the lung. And however, since we are inhibiting PD-L1 with this drug, we don't see any pneumonitis in the trials. And the response rates and the overall durable responses with MPDL3280 are very similar to the PD-1 inhibitors. So the main problem, as I mentioned, these drugs work really well, and they work, however, only in about 20% of patients, in unselected patients. And the problem is we can't, at this point, predict who those 20% of patients are who would actually benefit from this drug. And there's a lot of activity in biomarker development for these drugs. Preliminary data suggests that PD-L1 is actually predictive of response to these drugs. However, the problem is PD-L1, unlike any of the genomic biomarkers, is a very dynamic biomarker, and is very strongly influenced by the tumor microenvironment and inflammation and treatments. And there is a lot of spatial and temporal heterogeneity with this biomarker. And at this point, even though it seems to be predicting response, there are patients who do not have PD-L1 expression who also have significant response. So the FDA approval does not require PD-L1 positivity. But however, what's interesting is in several of these trials, we see consistently that patients who have been heavy smokers tend to have a better response to these drugs. So there's something about smoking status that tells us that, that there's probably like increased mutation burden in these patients and increased neoantigen activation that's probably generating more immune response against the tumors. And the fact that the tumors are able to mount a better immune response tells us something about the tumor, and perhaps those are the patients that have benefit from these drugs. So the work is still ongoing. We are looking at various surrogate markers to predict tumor antigen load. And unfortunately, most of the data that we have is based on whole exome. That is not practically feasible in terms of clinical use. So the work is still ongoing. So there are like several trials that are currently ongoing. I won't go into all these at this point, but it should be in your handout. So just to summarize, the therapeutic landscape for most advanced solid tumors at this point, the current strategies or treatment strategies is chemotherapy for frontline treatment. And it's based on like histology, the site of origin, and also like in patients who have some targets, oncogenic targets, then personalized therapy makes sense in that population. However, even with personalized treatments, the 5-year survival rate for most solid tumors is very modest at best. So there are like several ongoing trials with combination with cytotoxic chemotherapy, with immunotherapy, radiation with immunotherapy, and combination of various types of immunotherapy, like combination with vaccines and combination with various immune priming effects. So the goal is to increase the number of patients who would respond to the immunotherapy and have more patients live longer. So it's great that these are like a new class of drugs, and these drugs have just been approved in the last few months, and in the community, we haven't really seen a lot of patients actually being treated with these drugs. And in fact, like I said, in the early trials that I just described, the percentage of immune-related adverse effects is actually very low. It's like in the range of like less than 5%. So when you have such a low prevalence of immune-related adverse effects, and you have these drugs now FDA approved, and so we have to see, and all of us have to be very well aware of all the immune-related adverse effects that could follow the treatment with these patients. And the mechanism of these immune-related adverse effects is mainly related to the mechanism and the loss of tolerance of self-antigens. And as I mentioned earlier, CTLA4 is involved in the immune activation phase, and PD-1 is in the the effector phase of the anti-tumor immune response. So we see less of the immune-related side effects with PD-1 inhibitors. And the most common immune-related adverse effects are dermatitis and colitis. And pneumonitis also happens in these patients. We see less of pneumonitis in patients who are being treated with anti-PD-L1 compared to PD-1 inhibitors. Most of these side effects, thankfully, are very easily managed with oral steroids, and oftentimes depending on the severity of the immune-related side effects, oftentimes you would need a prolonged duration of taper, and some of these immune-related side effects can wax and wane as you get them off steroids, so they need to be closely monitored. And the key really is patient education, early recognition of these immune-related adverse effects, and as more of these drugs are in the community and a lot of doctors are using these drugs, we will be seeing more of these, and we need to be aware of all these side effects and manage them appropriately. And the key really here is to have a multidisciplinary care consultation, and sometimes there are patients who do not respond to steroids. We need to step up and have a broader consultation with specialists to help guide treatment of these patients.